Okay, so welcome everyone. Thank you for logging on this morning or this afternoon, or wherever you are, depending on wherever you are in the world. My name is Alessandro Reggio. I'm a project lead with the biosecurity team here at CRDF Global. In order to open this webinar today, I would like to now introduce CRDF Global's Senior Technical Advisor for Global Health, Dr. Julie Fischer. Julie?
Thank you so much. I'd like to thank everyone and welcome you all. Good morning, good afternoon, good evening. We have people here from a range of time zones, and I'm delighted to see many old friends joining and welcome those who are new to CRDF Global Events. I am Julie Fischer. I'm the Senior Technical Advisor for Global Health at CRDF Global, and I am delighted to be here today with a panel of distinguished experts in biosafety, biosecurity, and in capacity building across a number of related fields. Very quickly, in terms of housekeeping, I'd like to welcome you all and continue to encourage you to drop your names in the chat so we know who's here. That's fantastic for all of us. Thank you so much. In terms of questions and answers, this is a webinar format, so I do not have a way to recognize you verbally, but any questions that you have, you can register at any time during the presentation today by using the Q&A function in Zoom. It's in a bar at the bottom of your screen. If you click on that and enter your question, I will manage the questions and I will read them out loud to the panelists so that we can make sure to address all of the topics that are of interest today. In the meantime, again, I'd like to welcome you all. And what I'd like to do is invite our panelists to introduce themselves. If I went through their distinguished bios and all of their accomplishments, we might be here for the entire duration of the presentation this morning. So instead, I'm going to ask our panelists to please introduce themselves and give the participants today an idea of who you are and what you do. And then we will get started on our informal conversation and welcoming questions. Erin, I'd like to invite you to please introduce yourself.
Thank you, Julie, and thank you to CRDF for hosting this fantastic panel. A pleasure to be here with all of you. Good morning, good afternoon, good evening from all corners of the globe. It's so wonderful to see all these messages coming up on chat. My name is Erin Sorrell, and I'm an assistant professor at Georgetown University, where I direct the master's program in biohazard threats and emerging infectious diseases. And I'm the director for the Elizabeth R. Griffin program, which is a fantastic organization that's been around for a number of years, focusing on biosafety, biosecurity, and occupational health. My background is in virology. I'm a trained virologist and have since retired from wet lab research, focusing primarily on health system strengthening in the Middle East and North Africa, with a focus on lab capacity building and the international health regulations. So it's an absolute pleasure and honor to be here with you all and with my fellow panelists.
Fantastic, thank you. I turn to you, Jerry.
Yes, thank you, and good morning, everybody. It's also an honor to be with my fellow panelists and everybody that's participating this morning. And my apologies in advance if my dog starts barking. But I'm at Texas A&M University. I'm Associate Dean for Global One Health in the College of Veterinary Medicine, and also Director of the Pandemic and Biosecurity Policy Program at the Scowcroft Institute of International Affairs in the Bush School of Government and Public Service. Prior to coming to Texas A&M almost 8 years ago, I spent my career in government service, 26 years in the military that included Deputy Commander and Commander of USAMRIID at Fort Detrick. I'm also a former Principal Deputy Assistant Secretary for Preparedness and Response at HHS and a Deputy Assistant Secretary for Chem Biodefense and the Pentagon. I serve on a few advisory panels now, including the NIH's National Science Advisory Board for Biosecurity. So I think I'll stop there and turn it back. Thank you.
Thank you so much. And then finally, I'd like to turn to you, Greg.
Thanks, Julie, and hello to everyone joining us from around the world. My name is Greg Kolbentz. I'm an associate professor at the Schar School of Policy and Government at George Mason University, where I direct the Biodefense Graduate Program that offers certificates, master degrees, and a PhD degree in biodefense. My research and teaching focus on global health security, the proliferation of weapons of mass destruction, and the impact of emerging technologies on international security.
Fantastic. Thank you all so much for introducing yourselves. And again, I think that just from that, we get a sense of the rich and varied experiences our panelists bring to today's conversation. And so to make the most of that experience, I'd like to just begin right away. I'm going to ask a few questions and invite our panelists to reflect. This is, today we're not beginning with any PowerPoint presentations. We're not beginning with a specific set of policy recommendations in bullet points. This is an opportunity to really reflect on what we're experiencing around us. There's been so much discussion in the past year of lessons learned or lessons observed, depending on your background, and how we can use those to both respond more effectively to the still ongoing COVID-19 pandemic and to prepare so that we have strengthened systems to detect, to prevent, and to respond more effectively to emerging infectious disease threats of any source, so that we are ready to prevent the next pandemic. With that in mind, I'm going to turn first to the question of biological risk management, biorisk management. One of the challenges that we have seen globally during the COVID-19 pandemic was the immediate demand on laboratory systems, both on public health and diagnostic laboratory systems, to scale up their services immediately and to operate under those capacities for a prolonged time, almost 2 years now. And at the same time, the need to expand the number of laboratories that are capable of safely handling SARS-CoV-2 and other pathogens to identify, develop, and test diagnostics, vaccines, and treatments. So I'm going to actually begin with you, Greg. I know you've done a lot of work on understanding the current standards for high-level containment labs, and I'd like to ask you to give us your thoughts on what we can learn from the current experience and what we need to do going forward in terms of setting standards and being able to achieve those standards for containment laboratories and being able to work safely and securely with SARS-CoV-2 and other pathogens, given our broadened capacities for research and for testing.
Sure. So the pandemic has obviously highlighted the importance of having a robust, biomedical research enterprise, which does include maximum containment laboratories, which are commonly called BSL-4 labs, but obviously labs of lower biosafety levels as well. And in addition, the kind of debate over the origins of the pandemic have also raised the profile of biosafety issues, of disease research issues. And even if this pandemic is a naturally occurring zoonotic spillover event, it doesn't mean the next pandemic can't be the result of a lab accident or a gain-of-function experiment gone wrong. And the attention that has kind of been brought to these issues, I think, has highlighted a number of gaps that we have, both at the national level in various countries and also internationally. And at this point, there is no real international standard for these kinds of, for biosafety, biosecurity, dual use research oversight. There are voluntary guidelines, but there's no real international mechanism to keep track of which labs are operating at the highest levels of biosafety, the kind of research they're doing, any mechanism to ensure that they're doing so safely, securely, and responsibly. So this is, I think, going to be an important area to focus on in the future. There are kind of standards that are out there that can be adopted, but they haven't been. And more importantly, again, there's no kind of peer review mechanism. There's no forum where these laboratories can demonstrate their compliance with the highest levels of biosafety, biosecurity, and dual use research oversight. And as these labs grow in number, as their activities are scrutinized, I think there's going to be increasing demand from both policymakers and the public to have more transparency and to have more assurance that this work is being done to the highest standards available. So I think this is definitely going to be an area that's going to receive a lot more attention and is going to require, I think, some creative thinking both at the lab level, but also at the higher policy levels to figure out how do we ensure this research can go forward, which is obviously vitally important to developing new countermeasures and new diagnostics, but do so in a way that minimizes the risks that are generated by this kind of research.
I'd like to invite our other panelists to reflect on what Greg just said, and then Erin, I'm going to turn to you after that to actually build on some additional thoughts here. Well, Erin, if neither of you have any, oh, looks like Jerry's coming up.
Yeah, I do. I mean, I just want to echo Greg's opening remarks. I think our high containment laboratories really underpin our foundation of our public health preparedness activities. It is that underlying science, and we are going to need the high containment laboratories to do the necessary research to understand the pathophysiology, but most importantly, to develop and discover the next vaccine candidates, diagnostics, and therapeutics. It really starts at the laboratory level. But at the same time, it's kind of a shame that we've been talking about the need for international biorisk management standards for over a decade, ever since we began the initial debate over a decade ago about gain of function research and what's unnecessarily risky. And here we are, we still don't have an international framework. So I think that's really going to be a lesson observed that we really need to turn into a lesson learned once we get beyond the response phase. Over.
Thanks so much, Jerry. Erin, turning to you for initial thoughts, and then I'm going to actually come back to you.
Sure, and thank you so much. I couldn't agree more. I think the role of laboratories, both in terms of having the right capacities, the right response, not only to outbreaks, but for basic research is critical. Understanding host pathogen interactions is the bread and butter of understanding disease surveillance, prevention, and response. So labs have a huge role to play there. I think, to both Greg and Jerry's point, thinking about how investments in biosafety should match investments in biosecurity moving forward are critical. And I think that's something that we'll probably continue to repeat throughout this panel. So I'll stop there.
Thank you so much for those responses and for those thoughts. I'd like to again just take one moment to welcome those who have joined us since we've begun for this panel. Thank you so much for being here today, whether it's morning, evening, or midday your time. We are welcoming questions at any point. So if you have questions, please feel free to use the Q&A function. It is a little dialog box in the bottom of your screen on Zoom to register your questions, and I will read them and share them with our panelists today. Thank you again. Building on this issue of biorisk management and the demands that we've seen, one of the challenges of COVID-19 has been the challenge of surging to provide high throughput, high quality molecular diagnostics, including capacities of laboratories worldwide to conduct whole genome sequencing and to use that data effectively, added to the need to conduct PCR molecular diagnostic testing, to surge that rapidly and to surge all the capacities that go with that, from the point of specimen collection all the way through to data management, and to sustain that pace in diagnostic and in public health laboratories, while at the same time stepping up research, as we've just talked about, to try to develop the diagnostics, the therapeutics, and to test the vaccines that we need to actually respond more effectively to the pandemic. So, Erin, I'd love to turn to you for the thought of what the impact has been of this long-term surge demand and the challenges of implementing risk-based biosafety measures in this environment. If you could reflect on what we have learned, and then what we might learn and move forward from in terms of capacity building.
Great, thank you so much, Julie. Yes, I think, to your point exactly, diagnostic, public health labs, even private laboratories have really gone into surge mode for both diagnostic testing and for different advanced molecular characterization for COVID-19, for the SARS-CoV-2 virus. And research labs really expanded both existing lines and then new lines of research on coronaviruses, as we as a global community went into surge mode to characterize, to research this virus. This work critical, right, for both diagnostic testing to be able to detect and respond to this pandemic, but to really any outbreak, that's critical. And then research advances, again, are very important. And we think about how those lead to the improvement of life, both from a human, animal, and environmental perspective, right? Having that One Health approach is really important. I think what's interesting to note is during this surge response to COVID-19, WHO put out a new guidance on laboratory biosafety that emphasized this evidence risk-based assessment, right? Core competencies to look at a risk-based approach. And so trying to make it so that you don't have this one-size-fits-all approach to lab biosafety and risk assessments, which has been, I think, received well. The timing of it was challenging, right? Because this was being released at a time where everyone was working overtime, overburdened, overstretched, and under pressure. And so it was very hard to think about how to really figure out what works and test and implement these measures, which would have been a little bit more ideal during a routine operations, right? And of course, we can't control that. So that becomes a bit challenging. I think one of the hardest things is that people have been working at peak levels for a very protracted level of time. I don't think early in 2020, I would have made that same comment, right? I don't know that I think I was a little bit more hopeful in early 2020 that we would be kind of towards the end of this. So I think some of the lessons that we can say we have observed and hopefully can learn is the fact that there needs to be consistent and sustainable support for biosafety in the laboratory. And that's not just thinking about the policies, but funding that can allow for research and public health and even veterinary health labs, many of which are running diagnostics for SARS-CoV-2 to assist their public health infrastructure in responding and doing timely testing. And so looking at really how do we provide sustainable funding for biosafety that can match, again, that level of biosecurity, both in terms of, I think, the level of awareness that biosecurity has from global health frameworks, throwing biosafety in there as well and making sure that that gets the attention that it deserves. And I'll stop there and would love to hear from my colleagues as well. Thank you.
I'd love to hear any additions you'd like to add. Jerry, it looks like you're moving to unmute.
Yeah, and I was reading some of the comments here just now on that, and one of the thoughts actually when Erin was talking about that is I'm not sure if we here in the United States anyway that we recognize actually the biosafety funding just in our grant proposals and so forth. It's something that's covered in indirect cost as opposed to a line item in a proposal. Maybe that's something we should be thinking about, at least in our country and other countries as well, that it needs to be highlighted as a very specific cost element of doing the research and not just something that's embedded in the indirect and overhead costs that have to compete for other administrative and overhead costs associated with running a laboratory. So that's an initial thought just that spurred my thinking with Erin's comments.
Yes, Greg, please.
I mean, I think that this speaks to as both Erin and Jerry said, that the integration of biosafety into routine operations and at the management level as well needs to happen, for all levels of biosafety labs. And obviously, it's most critical at the maximum containment laboratories, but there are the risk of laboratory-acquired infections or releases at all levels. And if not only to protect the workers, but also, the public's trust, safety needs to be prioritized, again, at all levels, from the lab techs up to the head of the lab. And I think hopefully there is going to be some more progress on that as labs shift away from the kind of the emergency response that has been kind of consuming them, because there is a international standard called the ISO 35001 on biorisk management that lays out kind of a enterprise-wide mechanism for integrating biosafety and biosecurity into an organization's processes, procedures, policies, and that should really help drive safety and security to being at the forefront of how these labs operate. So hopefully that standard will be more widely adopted as labs are able to kind of spend a little bit more time working through those issues, as opposed to being consumed with kind of the daily demands on them to do the research and diagnostics that is obviously kind of crucial right now.
And Julie, could I add one more thing?
Please, yes, of course.
I think right now as well with Greg and Erin's discussion is the importance of leadership in the laboratory is absolutely essential. And as we think about training and education in our cooperative threat reduction programs, we ought to be thinking about the next generation and how they're going to develop as leaders, scientific leaders, but also leaders within their respective laboratories, because it really starts at the top in something like this, and you really have to embed a culture of that safety and responsibility and accountability. And it's just essential in our in a high containment laboratory that you have that strong foundation of leadership. And I think we can do a lot if we start educating the next generation. Thank you.
Julie, could I add one more thing?
Of course.
Okay, thank you. My brain starts working a little later in the day now, and I apologize. But actually, Jerry brought something up that made me think, oh, that's brilliant, right? Thinking about the fact that, well, Jerry says a lot of things that I say, oh, that's brilliant. But thinking about the fact that, we think about biosafety from a lab perspective, whether it's for basic research or implementation programs with partners in various nations, that's on our indirect costs, right? A lot of times we don't have specific budgets for biosafety, which is crazy, really, when you think about it. And as Jerry was saying that, I was thinking about the fact that so many projects that I work on, and as I'm writing grants, there's always monitoring and evaluation, right? There's always a framework to assess, is what I'm doing the right way to do it? How are we learning, right? Or observing what's going on? Why don't we have that for biosafety in laboratories? Why are we not testing protocols that are in place? Why are we not testing frameworks that exist that say, here's what was established based on norms and standards, based on what subject matter experts have put out, but how does it work in your lab? And I think WHO in that new risk-based approach, right, not thinking about the fact that every lab looks the same, is a great way to start. But let's give everybody a chance to really test these out and see what works, and then really get that out there and have a public forum to share experiences and share data to be able to say, this is how an SOP on waste management can work in a low resource setting if you don't have an autoclave that's going to work every day. Here's another way to inactivate a virus so you could work on it at a bench instead of having biosafety cabinets for certain different certain experiments. And so I think that's something that the Griffin program particularly is really interested in working on, and I'm sure a number of other partners are as well, but something that I think really deserves more attention than it's getting. And now I'll be quiet. Thank you.
And if I could just kind of add on top of that, there's also a neglected area of biosafety, which is biosafety in the field, which has been kind of, again, highlighted by the current pandemic, but the lack of standards for most countries and at the international level for how to safely collect specimens from wild animals that might be infected with a zoonotic disease is vitally important, especially as there's research projects that are underway or going to be launched that are going to engage in massive widespread collection of these kinds of samples. So the idea of biosafety has to be taken outside the laboratory context where it's been kind of the dominant mode of thinking about it, and looking at the entire research process in order to minimize risks to the people working in the lab and for the lab, because this is, again, another area where there needs to be more rigorous research done on what is the best way to do these kinds of sample collection in a way that will protect the health of the workers.
And if my panelists, will you indulge me in going ahead and addressing some of the questions that have come up, because I think they're very relevant to the discussion we're having now, and we'll manage our time to leave time to talk about some of our other key topics we want to touch on. Is that okay with everyone? All right, we have several questions here that touch on very related topics, including the experience, for example, the discussion of this experience in the Philippines with molecular diagnostic labs expanding rapidly in response to the need to surge testing for the pandemic, and now the question of what do we do with this expanded network of laboratories in terms of monitoring them and maintaining them and understanding what they'll do with all the virus samples that are currently stored, for example. And that relates to the point that it was raised by some of our other participants, including the question about emphasizing biosafety and potentially, thinking now about biosecurity for dealing with SARS-CoV-2 isolates, but not focusing on as much on the issue of laboratory-acquired infections, which has been extremely difficult to understand in the context of the pandemic, while there is so much ongoing community transmission in the areas where laboratory testing is happening. So I think together the questions really focus on, we've expanded our diagnostic laboratory networks, including those with molecular capability. What can we do moving forward to, especially learning on lessons of the past, to help monitor and support them in biosafety? What can we do to draw more attention to the need to look at COVID-19 as a potential LAI and understand what we can do? Coming back to that last point that Greg made about, and that you had started with, Erin, on being aware of the safety of laboratory workers, both during specimen collection and while actually carrying out testing and manipulating virus. And then another question about that's related about what are the challenges for building laboratory capacity in a clinical setting, so for clinical and diagnostic laboratories, as opposed to for research settings. I think we can begin with those, and then we have some questions about funding and training that we can move to afterwards. So the topics are, what do we do with this expanded diagnostic network, the expanded diagnostic capacities that have been developed in many countries to support them moving forward, especially with awareness of biosafety? What can we do about drawing more attention to laboratory-acquired infections? And then what are the specific challenges for clinical and diagnostic labs as opposed to research labs? Who would like to start?
I'll go ahead and start out. I mean, it's a really good thought, and all of a sudden I'm searching my my memory, and actually I don't recall much discussion about SARS-CoV-2 laboratory-acquired infections in the response phase. And so, in fact, are we doing a good enough job in just occupational surveillance in our laboratories as we moved into the surge phase? We probably are. I'm just not. Haven't read the right publications, but it's something that needs to really be front and center, like my comment earlier about biosafety, that we also need to elevate the importance, particularly in a surge environment, the need for enhanced occupational exposure surveillance, because the scenario is real easy. If a lab worker were to test positive for SARS-CoV-2, it's real easy to say, well, it's community acquired. But so I don't know, we need more data probably. Maybe it's there and I'm just not aware of it. So others can correct me if it's there and I'm not aware of it. But that's my initial thought, that that occupational surveillance is going to be really, really critical. And it's going to be, we need to have more staff also to do that when we go into surge mode. And it can't be another duty as assigned.
And if I could just add to that, I think, looking historically, at least at laboratory-acquired infections for other coronaviruses and looking at SARS and the lab-acquired infections that occurred in 2003, 2004, really were because of human error, right? It was not engineering controls. It was not a facility directed issue. And that really came from, I think, again, to our points about people being overworked and under stress and having the protocols in place that understood how, if I have to inactivate this virus in order to work on the bench, here are the steps I need to take, and here's how I can test that it is actually inactivated. And so taking the time to really not only understand the SOPs that are in place for safety and security, but also having consistent training and consistent oversight on that, I think is critical, right? Because nobody intentionally exposes themselves to something in the lab when they're working very hard, either in response from a diagnostic or a research perspective. So it's really looking at looking at least examples in the past. Many of these laboratory acquired infections have happened because of human error, both at home and abroad. And so I think that's something that we can continue to focus on, and the importance of having an open chain of communication, I think, at the facility level, and then institutional and national as well, mechanisms that you can think about how you can report either real incidences or near misses. and then be able to figure out how do we learn from those without getting judged or having some type of mark on our facility or on the individual. I think there needs to be a little bit more transparency in that, because we can learn as a community from those.
In terms of the surge in molecular diagnostic labs that one of the audience members was referring to, I think the pandemic was not only a stress test on laboratory capacity, but also on kind of the regulatory and policy side as well. And in the U.S. in particular, the pandemic really revealed a number of shortcomings with our approach to approving diagnostics. We have a policy called EUA, Emergency Use Authorization, which is kind of a shortcut to getting diagnostics and medical countermeasures out into the field quickly. But that system really broke down when it came to diagnostics and caused a lot of bottlenecks. So I think in contrast to other countries like South Korea, very well integrated their development of diagnostics with the kind of testing and certification required to make sure that they were producing accurate results, and then integrate the results of the testing into their public health strategy in terms of isolation and quarantine of confirmed cases and suspect cases and the contact tracing they were doing. So I think, again, maybe now or maybe once the pressure on labs has been reduced somewhat, I think it's be valuable for countries around the world to kind of reevaluate the role of diagnostics in their disease response, and how well designed is that system for providing easy access to the diagnostic test, and then integrating the results into their public health strategy, right? Because just having a result that one individual knows is not, it's useful for that individual, but it can be much more useful at a system level if it's integrated with other data that the public health authorities have, and they're able to act on it and respond to it. So I think there's lots of very valuable lessons observed and hopefully lessons learned from that will start coming out more, and that there would be great for there to be some kind of forum to share those results among labs, to enable them to learn from one another and how to improve their overall performance moving forward.
Yeah, please, Jerry.
Yeah, so I'll just maybe add another theme in here with laboratory acquired infections, and what can we do to just elevate the I don't want to say the importance, but the fact that they happen. And it's a kind of a dual-edged sword. Some laboratories may be afraid at their communities. They don't want to talk about it because the community, the public may not like to have laboratory. The knowledge of laboratory acquired infections may turn the public against having a laboratory in their community. But the only way to overcome that is transparency, and discuss it and to talk about it, because to err is to human. And most of the laboratory acquired infections are just due to human error, and most of them are no threat to the public and the community. But the fact that you have a culture that encourages and reporting of even the most minor of infraction is absolutely essential. So even the most minor infraction can be studied for after action and to prevent a future minor infraction and error. But to talk to the public about that, to earn the trust and confidence of the community that the laboratories work in is very, very important. And the only way to do that is be extremely transparent and talk about the most minor infractions and how the laboratory has a system to mitigate one, exposure to the laboratorian, and two, a breach of the laboratory. So transparency and talking about laboratory acquired infections is going to be important, as opposed to trying to dismiss it as not very significant.
Yeah, thank you. And I think the point about, something that has been discussed for a long time is how to create a non-punitive way of reporting laboratory near misses and incidents so that we can learn from them. The way that, we often use airline safety as aviation safety as the model. It's not a perfect model, but certainly there have been a lot of lessons there about what you can do in terms of safety culture by being more transparent about those near misses, as well as the actual, as well as events. And I think there's a lot to learn here from the occupational health and medical fields as well, in terms of what they've tried and what they've struggled with that we could build on. I'm going to take just a few more minutes. We have several relevant questions and comments here. I want to address what we have in the box right now and then move on to some other related topics. But I'm going to target some of these questions. Beginning, Greg, with you, Dr. Saeed for Jordan asked the question about two questions, and I think well, I'll start with you and then ask others if they want to comment. Again, if the next pandemic required a BL3 setting for diagnostics, how would that affect the ability to respond, given that not all countries have that kind of capacity in place? And then he also asked a question about the news on NIH funding to Wuhan Institute of Virology. I mean, I think that's been discussed a lot in the public arena. I don't know that we want to really focus a lot on the specific details here, but just the question of, we now have a lot of widespread awareness that there are risks posed by some research, that the fact that it's difficult to, the fact that it is a viable scenario that the WHO and other experts have identified, that laboratory transmission is a scenario, regardless of what evidence we have or what we'll ever know about the details at the laboratory level. What do we do about to address some of those concerns as we build in new protections and new awareness moving forward?
So let me take that second question first, and I think that this again kind of reveals some of the gaps and problems with the U.S. System for doing oversight of dual-use research. And again, without getting into the details, I think that this was research that was not handled very well, either by NIH or by the grantee, in terms of doing it in a safe, secure, and responsible manner. And even if this has absolutely nothing to do with the outbreak of COVID-19, which I don't think it does, again, it highlights the gaps in the current policies that we have, and the need to have a much better understanding of the types of research that's being conducted, possible risks it poses, ways to do that research with alternative methods that are safer, and then how do you weigh the risks and benefits appropriately and put in the right level of safeguards so you can do the necessary research, but not do so in a way that's going to pose unnecessary risks. And I think that this is instructive for the US, but also we're in an unusual position where we're one of only less than a half dozen countries that actually have policies governing dual-use research. So in most countries, this kind of research would be funded and proposed and funded without anyone asking questions about the biosecurity implications or the dual-use research implications. So I think that also should serve as a wake-up call that other labs in other countries might be doing this exact same research, but no one's asking these kinds of questions. And therefore there needs to be, again, I think a much broader conversation about the so-called gain-of-function research, but basically any research with pathogens that could produce a virus that is more transmissible and more lethal, and a potential pandemic pathogen. I think given the global risks that kind of pathogen could pose, I think there is a need for a broader international discussion about what are the right standards under which to conduct such research, again, to make sure it's being done safely, securely, and responsibly. So aside from the specifics of the particular grant, I think that there's, again, a much broader issue that that's being raised here. On the initial question about the BSL-3 labs, actually, I would defer that to Erin and Jerry about on the capacity building side, since I think that's much more in their wheelhouse.
And I'm going to say that actually is, I think, related to some of the other questions here. There's one comment really on what can we do with all the expanded lab capacity after COVID-19 is passed, and that's and repurpose it for surveillance of new of emerging zoonotic diseases, which is, I think, something we're going to touch on more. But I'd love to hear, Jerry or Erin, your thoughts on this. What do we do about emerging infectious disease threats that require higher level containment or have been identified as BSL-3 organisms, for example, or require BSL-3 protections?
Oh, that's a hard question. That's a really difficult question when we think about the capacity, that surge capacity, and it absolutely requires a BSL-3 for the diagnostics, because I'm not sure that we would have sufficient laboratory capacity to do that. So I think we're going to have this is probably a topic for research. How do we plan for a surge that initially it does require BSL-3, but what can we do to actually render more safe the sample, that it then can be molecularly, do the molecular diagnostics at a lower containment level is probably what we're going to need to do. And that's we just need to invest some research dollars and effort to determine what that would look like and what would be the procedures and protocols to render more safe a diagnostic clinical sample that can be worked at a BSL-2 level. I think is probably what we should do. I don't think the answer is let's build more BSL-3 labs for the potential that we might need them. Now we may need more BSL-3 labs, but it needs to be very thoughtful consideration of how we would do that, because we have, I would say, a proliferation of BSL-3 labs around the world. I'm not even sure we can track all the BSL-3 labs in the United States unless they're registered under the Federal Select Agent Program. So it's going to take some careful consideration. And I'll turn to Erin, and I would like to come back to the gain of function question too, but let's stay with the BSL-3 question first.
Thanks, Jerry. I'll try to be concise. I think one of the important things is looking at how much work we were able to do with this pandemic without actually having a virus sample in our hands, right? Just having the sequence. Laboratories were able to develop diagnostic tests to be able to start testing, patient samples. Now, having those samples may have required containment, but we already have, and I think to Jerry's point, some really great molecular diagnostics that allow us to work on emerging and novel diseases at some relatively basic lab levels, which I think is critical when we look at a global response. I too am not a huge fan of thinking about expanding high containment labs, and mainly just because it's so much money, so much resources, and the amount of time just to operate may not necessarily be a return on investment in terms of being able to really develop the capacity at a technological level in terms of having laboratory workers trained, having the right PPE and biosafety measures in place that you can then really operate at a BSL-2 2+ level with proper measures in place and be safe and effective. And so I think that is something to consider, is what do we really need to be able to respond? And just speaking from a retired influenza virologist, thinking about at a global level, the mechanisms and the networks are in place to surge in response to an influenza outbreak. I know that this has been used in the past, and people have talked about, are there, pathogen families, or is there some type of network that could be novel and emerging diseases? But the right labs that have the right capacities at the diagnostic or the molecular level for either, basic testing and or research can really adapt, right, depending on the type of pathogen that rears its ugly head and what we have to respond to. So we're never starting from scratch. And so it's really a matter of how do we develop either regional or global networks that can assist in real time when we need to, versus having people kind of sit and twiddling their thumbs and creating labs that are empty until an outbreak occurs. So that's a very simplistic way of looking at it, but I think that we can really take advantage of capacities that exist to apply them to greater problems.
Thank you so much for all of your thoughts on that. I think what we're going to do now is we still have some excellent questions here that are related to address, but I want to make sure that we move on to a couple of topics that are very closely related to what was just raised, and I think will still be very pertinent to these questions. And that's building on this topic that you've all just explored of what do we need to build and how do we build on what we already have. Jerry, I'd love to turn to you to talk about, given your experiences in supporting the development of vaccines and of thinking about how to roll them out in the US and worldwide, to build on that very question of, what do we have that we can build on, thinking about what we've learned from the rapid development and the rapid deployment of vaccines that we can build on to develop capacities to respond more effectively to other emerging disease threats.
Sure. And first, I just want to say that the biomedical science enterprise has just been extraordinary. When you think about here globally, but I'll just use the United States first. in 11 months, I mean, to the day, that the first SARS-CoV-2 genome sequence is made publicly available on January 11th, 2020. And then exactly 11 months later, on December 11th, 2020, that the FDA granted emergency use authorization for the first COVID vaccine. I mean, that's it's just an extraordinary public health achievement, that we haven't fully grasped that achievement yet. But it wasn't built, that 11 months was extraordinary, but it was also built upon 20 years of or more of investment in science, investment in biodefense, and a lot of hard lessons learned along the way, a lot of successes and failures along the way. There was, I think Greg mentioned emergency use authorization, but that was something that came about with Project BioShield in 2004. It took another decade for us to figure out how to more effectively use it. We didn't quite use it effectively for the SARS-CoV-2 diagnostics. But Defense Production Act was something that we looked at as a policy in the H5N1 pandemic preparedness era between 2006 and 2009, and at least had policy options that allowed it to be utilized this time, and just the investment in messenger RNA vaccine platform and some of the DARPA grand challenges that just stimulate the industry and academia to think outside the box. All these things, led up to why we were able to do this in 11 months. And then, some of the metrics is in the United States, we've distributed over 500 million doses of vaccine. And I don't know, last time I looked at the data, I think 420 doses had been administered, and over 65% of those 18 and older are now fully immunized, and 85% of the most vulnerable over 65 are fully immunized. That's all great news, but and then globally, there's been 7 billion doses of COVID vaccine administered, and that translates to about 3.5 billion people around the world who've been in 2 shots, assuming 2 shots, about 3 to 3. But there's most of that, though, the bad news, or the good news and bad news, is only high income countries really have access to the vaccine. And it's only about 2% of the population of low income countries have access to vaccine to date. And so this is something that is extraordinary as the vaccine development and rollout has been. We have to think about the future. How are we going to have equitable distribution of the global vaccine, and what is the capacity that we're going to be needing to more rapidly produce vaccine on a global scale, so that we, in the future, that we have much more than 2% of low income countries this far into the pandemic, so that we can overcome that deficit. So anyways, I think there's a lot of successes, but there's a lot of lessons learned. How do we maintain the momentum of lessons learned in Operation Warp Speed, at least in the United States, and then every other country that has been manufacturing vaccines? It's the same kind of success story. But we're going to have to think about what do we need to have a distributed manufacturing system, and we're going to have to think about what are some smaller footprint capabilities that we can democratize, so to speak, vaccine development and manufacturing in low middle income countries. You can't do it in every country, but we can have a strategy that looks at regional vaccine production, manufacturing, advanced development that could serve regional nodes and still rely on, I guess, larger vaccine manufacturing where scale of economy is important. But I think we have the ingredients to do it. We just have to have the political will to develop a strategy and resource it.
Thanks so much, Jerry. Erin or Greg, do you want to add thoughts to that? Greg, it looks like you're ready to lean forward.
Yeah. So, one of the achievements, as Jerry rightly pointed out, is the development of the various vaccines in a very compressed timeline. But unfortunately, the distribution has really been lopsided, and in part this is because from the beginning, there was much more competition at the international level than there was cooperation. And this, given that this was a pandemic affecting, every country in the world, right, this really needed a much more unified, coherent, organized international response to do it. And at the end of the day, the WHO there's a limit to what kind of, power and authority it has. It really takes the, leading countries in the world to work together to create a structure and a strategy to produce enough vaccine and distribute it, widely and equitably for it to really, contain the pandemic. And unfortunately, we just didn't see that. And, to me, one of the real lessons from the pandemic is that when the great powers compete over global health during a pandemic, the only winner is the virus. And that's a very unfortunate lesson that we definitely observed and hopefully we've learned. And I would sincerely hope that we're able to do better next time.
Erin?
Just very briefly to add, I think, Greg and Jerry make all very strong and excellent points. And I think, I just keep thinking back to pre-pandemic, all the simulations that were run, both at the national and global level, right? And we've all participated either as facilitators or participants in them. And I think it's very easy to say, well, here's our guidelines and we're going to follow them. But then when push comes to shove, you really start looking inward. And that's unfortunately what really happened. And I think to Greg's point, right, the virus won. If there was a, perfect way of communicating how equal distribution, equitable access to vaccines actually protects us and every nation in terms of being able to prevent variants from arising and thinking about the continuous evolution of this virus and potentially viruses to come, we need some kind of really great PSA to think about how to affect change in that way. Because I think, unfortunately, the next time this happens, everyone else is going to think about themselves before the world, sadly but true. So how do we think about how to change that? And I don't know that a policy necessarily is going to fix it, but we're going to have to continuously push and engage and really exercise how to do this properly, and how that will actually promote public health and containment much quicker than getting whole nations vaccinated before the globe. So I'll get off my soapbox and go on mute.
Yeah, and speaking of exercises, we actually had a real world event called the 2009 H1N1 pandemic, and we saw the same phenomena play out that time. Fortunately, that pandemic was not as serious as we first feared. And there was some discussion about the need for global access, but soon after that, the pandemic was over and we incorporated some lessons observed. We didn't incorporate global access as a lesson learned, and here we are 10 years later. And I hope we can incorporate some lessons observed to create a pandemic vaccine manufacturing network. The hard part is, what is the business model that would underpin it? Because you just can't turn a manufacturing facility on and off. It's like a high containment laboratory. You just can't turn it on and off. You have to sustain it during the periods of crisis, and it has to have a function during the periods of crisis. But I hope we have the political will and the resources to solve it this time.
Thank you to all the panelists for those responses. There's questions that I think are relevant to this topic, and I think to summarize a couple of the questions about, we're going to come to the question of disease surveillance, but two topics I think we could focus on together. Dr. Apostolides, and I apologize to you if I'm saying that wrong, from South Africa, has posed a couple of questions. One we'll touch on zoonotic disease surveillance, but how basically I think the overarching question of, as we think about proactively about the use of vaccines, what are our criteria, what are our rationale as we think about not just the issues that you've raised here about making them available, but determining, what are the criteria for use of a preventive vaccine, for example, for an emerging infectious disease before a country is deeply affected. How do we plan for that, and how do we develop those rationales? And then a second question from Dr. Mahmood on how do we how do we, as Erin, your point about what do we do to make sure this doesn't happen next time, how do we include this topic of preparedness for pandemics and other issues when we're training future health professionals, at the secondary level, at the graduate level? What are we going to take forward and train people to do in terms of preparedness and decision making? So those are two related but separate questions. Looking for responses from any of the panelists.
Sure, I'll maybe start with the preventive vaccine. I think another excellent question, and again will require a lot of thoughtful consideration. But I think vaccines, like any medical countermeasure, and vaccine particularly, there's always a risk-benefit calculation about when you administer a vaccine, particularly on a population level. And so I think you really have to have the real risk of an imminent threat to warrant, or already an ongoing outbreak to warrant a policy decision to make a pandemic vaccine available. And so it's hard to predict, though, what that next pandemic virus is going to be. And so that's going to be a challenge about preventive vaccine versus a pandemic vaccine. Now certainly we have potentially vaccine preventable diseases already. They're endemic in countries around the world, and where the science allows, then we need to drive some science and development to improve our ability to deploy preventable vaccines for endemic diseases that sporadically cause regional epidemics, so that they're available, that could be used in a preventative mode or post-exposure prevention as the science might dictate. But the bottom line is we have to really look at the risk-benefit analysis prior to administering a population-wide preventive vaccine. And then the preparedness education, I'll just jump into that as well. I think that's a really good point. And before COVID-19, pandemics were not on top of mind for most people. But I think post-COVID-19, the catastrophic implications of pandemics are now top of mind, and I don't think they're going to go below top of mind for at least in the near future. And so now is the time. I do think the next generation are much more interested in, actually one of the positive things that I'm witnessing, at least in my university, is the next generation seems to be much more interested in public service and perhaps careers in public health and public health preparedness. And I'm certainly doing what I can to try to encourage that dialogue and discussion about things that people can do to make a difference in their communities in the world through public health, global health, public health preparedness, and all the disciplines associated with that. I'll stop.
To add on to Jerry's point about education, when medical students are in school, they're taught to think, when they hear hoofbeats, that you think horses, not zebras, right? You think of the most common ailment, not some novel pandemic threat. The problem is a pandemic is not just a zebra, it's a stampede of zebras. And doctors on their own are not able to handle a pandemic. It really is about the healthcare system and its resilience that really matters here. And again, we've just seen lessons again and again and again about how healthcare systems in the United States and Europe were just totally unprepared and were overwhelmed by just the volume of cases and the level of hospitalization needed and the intensity of interventions and how long it took, that really caused system-wide problems in a lot of countries. I thought they were much better prepared. So I think this is an area where there needs to be a lot more closer examination about what is it about our healthcare systems that either make them brittle and break under pressure, or what can make them more resilient. And I think we need to look at both cases where things went horribly wrong and also cases where we saw healthcare systems respond with resilience and be able to adapt and cope with the challenges they were being stressed with. And again, going back to a point that Jerry made earlier, right? A lot of it is about leadership and making sure that hospitals are investing the right resources in preparing for these low probability but high consequence threats. but again, also kind of the policy and regulatory environment that incentivizes, encourages them to prepare for these kinds of events. Because no hospital or healthcare system is going to willingly spend millions of dollars on extra ICU beds or extra resources that would only be used very rarely in the event of a pandemic if they're not expecting a pandemic, but once every 20 years or 30 years. So what's the role of governments and public-private partnerships to make sure that those kind of surge capacities are available, when needed for a pandemic, a mass casualty event, natural disaster, or what have you. So I think there's a lot that needs to be done at the system level to be able to be in a better position to cope with the next pandemic, which is inevitable, but we don't know exactly what kind, exactly when, and we need to have policies and systems in place that are able to cope with these, even if we can't predict exactly the nature of them ahead of time.
I think just adding on to that, that all hazards approach, right, to thinking about preparedness at the medical care patient centered approach is critical. And I think now more than ever, and I think all three of us coming from academic institutions is great, thinking about the next generation of individuals either going into healthcare as clinicians, as nurses, as NPs, et cetera, and thinking about how, as Greg mentioned, looking for those zebras is critical. I think looking at it from a policy and programmatic perspective, understanding how diseases emerge and the fact that it's not just the health sector that needs to be ready and thinking ahead. If we do a case study on SARS-CoV-2, for example, and say, okay, we have a virus that emerges, it's novel, we have some basic info on it, social distancing, mask wearing is going to work. Okay, the hospital level, you'll be able to contain because most people will practice that. We'll scratch that out. No one's doing it. Now you need more ICU beds. Oh, and by the way, supply chains are strained and the maritime trade is completely blocked. And thinking about all the different pieces of the puzzle that we have now lived through, I think is critical as we look at training the next generation. It's not just about the science. That is critical, and understanding that host pathogen interaction is critical. But thinking about the larger pieces at play, you can have the best treatment possible for a disease, but if you can't get it to your patient, it's no good. So I think thinking about really that all systems approach to training in global health is critical for this next generation. And I think them walking into their jobs and their careers, knowing that it's not just about health, but it's about environment, it's ag, it's trade, it's transportation, it's going to be really important. And I think I'm hopeful that things will change because of that.
Yeah, and if I could just take the prerogative to inject there with Erin's comments and back to vaccines. And I think one thing that we also need to think about are veterinary vaccines and animal health vaccines. And there are some animal pandemic viruses that are specific to livestock and don't cause human morbidity, mortality. But there's some that are zoonotic. And so I think there's more that we can do to think about applying the lessons learned from the COVID vaccine response to also animal vaccines. And I'll stop there.
Actually, I would love to springboard from there, Jerry, to talk a little bit about zoonotic disease research and what we, again, learning from what we've experienced during COVID-19, where you think we need to focus priorities and investments in training, in research, and in the capacities to support that research at the bench and in the field moving forward. And then I think we'll come back and talk a bit more about disease surveillance. I want to make sure we do leave time for some of these really excellent questions in the box as well. So zoonotic disease research and next directions.
Sure. I think, well, one, I think we, at least in the United States, and I think actually this is where other countries do better than the United States, is we don't have a coherent One Health strategy. And a coherent strategy to think about zoonotic disease and how we mitigate appropriately the potential of a zoonotic epidemic or pandemic. And so we have multiple agencies that fund a little bit around the edges of zoonotic disease research, but we have no coherent strategy. So number one, we should do that as a nation. And exactly what that would look like, I'm not quite sure. And I think that is also related to our lack of a coherent strategy. But I think pandemics, there's no doubt that emerging infectious disease outbreaks are increasing with much greater frequency, and most of them, and not all, in the last 20 years are zoonotic in origin. And it's really hard to predict what Mother Nature's going to do, despite some of our research efforts that have tried to focus on predicting the next pandemic virus. Mother Nature is very hard to predict, and we're not going to stop the next spillover event. So what can we do to detect that next spillover event from a zoonotic virus from a wildlife species, domestic animal, livestock to humans? And so I think we need to be really focusing a lot on what are the research efforts to best deploy and build capacities, public health and animal health capacities in areas of the world that can detect that next spillover event quickly, and then take action from that information quickly to mitigate its spread, to mitigate the potential of a regional epidemic that could turn into a pandemic. So I think, and we've done a lot of things to try to promote institutional public health, animal health capacity building, and they're all good things to do, but we probably need some underpinning research to actually help guide us with more evidence base of how best to deploy diagnostics and deploy, if we do need to invest in laboratory capacity, how best to do that in a safe, secure manner around the world. So I think, one, the research is underpinning what's really useful to detect an outbreak before it becomes serious. And yeah, I mean, I think that's really, I think, and we have to do this in a way, whatever research we do in zoonotic diseases, we have to make sure we're not doing something also that increases the biorisk for any region or the world in doing this, and particularly if it involves some kind of laboratory characterization. We don't want to create an unnecessary biorisk. And then I think we need research also to better understand how to manage the human, wildlife, animal interface, where people are increasingly living closer to food producing animals, and particularly areas of extreme poverty. And so we might think it's obvious how to mitigate that interface, but I'm not sure if it is, because we have to account for cultural appropriateness and in different areas of the world, and figure out what is the best way to mitigate the dangers and risks associated with that human, animal, and environmental nexus. I'll stop there.
Also seems like quite the burden to ask the people who are being driven by market forces to also be the bulwark to protect the rest of us against the emergence of diseases at that interface. But Erin, it looks like you're ready to respond.
I just wanted to add just very briefly to Jerry's comments, to think about also the fact that climate change and migration are going to push us even closer together, now more than ever. While we welcome having more and more neighbors, maybe we need to think about what that means for where we live, how we use land, how we look at water sources, and not just at the local community or national level, right? Having systems in place to think about how to adapt, both in terms of land use, agricultural practices, livestock practices. All of these are going to be drivers of zoonotic risks and potential spillover events that would not have occurred, years or decades before. And so understanding that our risks are evolving because of mass migration events, because of climate. These are things that are going to continue to happen. So how do we look at considering them in the threat perspective as we look at agents emerging? We need to think about these as well. So I just wanted to add that. Thank you.
Thank you. And then Erin, to build on that, I think one of the questions we wanted to focus on, and again, there's a lot of questions on biosafety, biosecurity I want to come back to in protecting healthcare workers, but to just build on that quickly, one of the challenges here that Jerry has already highlighted is that ability to detect when a spillover event happens rapidly enough to take action. I'd love to invite you to start off just a discussion here briefly on what we've learned about disease surveillance systems specifically, and thinking about disease prevention as part of surveillance as we move forward with what we've observed here during COVID-19. So I'd love to invite your thoughts on what we could build on specifically moving forward.
Thank you for that. I had my PhD advisor always said, if you're not looking for it, you can't report it, so you don't have the outbreak. And I think that still holds true when you think about the fact that surveillance systems are in place really to be able to detect quickly and to take effect. If we do it right, we have nothing to report. And so it's hard to show a return on investment, particularly as we look at systems politically and financially to support our surveillance systems. What I've had the pleasure of working in and partnering with a number of countries globally, and I think do a much better job actually than the US in that One Health approach. Systems are in place really at an informal level to think about how to, your counterpart in either the livestock or the agricultural ministry, in the public health ministry, potentially in wildlife ministry or fisheries, depending on how your government is structured. But having those formal systems in place and having a formal mechanism to report when events may be occurring, I think is critical. Something that we've seen build up from experiences, looking even at, there's a lot to be dissected and investigated and studied in this SARS-CoV-2 outbreak. But I think one of the things that we can look at as a positive is that the surveillance systems that were in place that detected this atypical pneumonia came out of investments from SARS, the original, right, of 2003, systems in place at provincial levels for surveillance systems of severe and acute respiratory illnesses. So having systems, I think, at the subnational level, both in animal and human health, are critical for the detection and reporting. Reporting is key. Having mechanisms, I think, to report up, over, up and down, over and across, right, in all angles, in all directions, to make sure that everyone that is needs to be aware can react and can really look at response. And I think the fact that historically there has been a challenge of visibility and transparency in potential reporting, that needs to be corrected. And I think something near and dear, I know, Julie, to both of our hearts is risk communication. So thinking about how are you communicating the risk for a potential event and not raising alerts too high for people to overreact, but to at least understand there might be a potential risk there. So I think those are some, to me, key aspects of having a very strong surveillance system in place to be able to contain and mitigate a threat as it's emerging versus it already either being a national or regional issue.
Thank you so much. Jerry or Greg, do you want to add on to that?
I mean, one thing I just want to highlight, which is something that's been a rather disturbing trend in this current pandemic, is the politicalization of public health data, and that politicians have either suppressed or manipulated the data to make their policies look good or to downplay the threat. And I think that's really corrosive to not only the practice of public health, but also the public's trust in public health. I think it's a very dangerous, very slippery slope when that starts to happen. So, hopefully, in the future, we'll be able to kind of better insulate the public health, data and reporting from those kind of political influences, in individual countries, but also having, again, international mechanisms to do a better job kind of, verifying the validity of the data that's coming out of countries. Because early detection is key, but also once an outbreak is ongoing, having that data about cases and prevalence and the type of, whatever variants might be spreading is really important as well. So, that I think that whole area is going to need more attention. as well moving forward to make sure that policymakers and public health practitioners are getting the data that they need and it's accurate and reliable and timely, and the public has confidence in it. And I think that's going to be a major challenge in the future as well.
Yeah, a couple things, I think genomic sequencing, rapid genomic sequencing, just to characterize the variants of SARS-CoV-2 has been incredible, and some countries are very good at it and some are not as good, but I think that's going to become almost embedded in our surveillance systems going forward. Or we need to, look at that, how we do that going forward for sure. And I think one other thought that came to mind is, boy, our scientific enterprise has been unbelievable. The amount of data, information, and studies that have come out, and it's very, very, very hard to kind of keep up with all the information. And I think one of the things that we lack is a way to integrate all the data and information, and to kind of do the so what analysis of all the different studies that are coming out on a weekly basis. So integration of data is going to be important, and that may help mitigate the misinformation and that has been happening that Greg alluded to. So integration of data is going to be important of all the publications that come out just daily.
Yeah, thank you so much. Those are all really fantastic points, and I can't believe we're already at 10:15, so we have 15 minutes left. I would like to go through some of the questions that our participants have posed, which range from specific to very broad ranging, and then make sure we leave a few minutes at the end for our panelists to, I'm sorry, this is the world of Zoom, to give, my phone makes music, to give some quick closing thoughts for us all. So I think coming up to that point that was just made about integrating data and the so what question, one of our for the love of God. My apologies. One of the questions here, or a comment that was posed, is the question of, how can we do a better job integrating data across healthcare systems to help in early detection of critical disease patterns? And I think that's very, very connected to questions that have been asked about One Health. And that's, how can countries move into a One Health framework, and how long does that take to begin working effectively? And how do we? There's one very challenging question here I'd like to add to that, which is, where are the gaps, the missing measures for effective control in the COVID-19 pandemic that we can highlight and learn from, and I think approach now as well. So I'd love to go around our panelists here and respond to all or some of those questions. How do we move forward with One Health? How do we do a better job sharing data across health systems? And where are the gaps now, the critical gaps? Please go ahead, Jerry.
I'll start with the critical gap. And I think from the start, the most critical gap has been communication, risk communication. And it continues to be a critical gap. And it has impacted trust in government, trust in public health. And so going forward, we've got to be able to do a much better job on risk communication, and that's just to me is the critical gap. We can talk about technology gaps and other policy gaps, but if we're not able to effectively communicate from between the government authorities, public health authorities to the public, and vice versa, from the public to our authorities, then that we're just going to continue to have major challenges.
In terms of the question about One Health and how to make that a kind of national strategy, I think you really need to follow a multi-pronged approach to achieving that. I mean, you need definitely a kind of a top-down approach where, the leadership in a country or ministries of health, right, have this as a priority and something they want to work on, because inherently it involves crossing bureaucratic and jurisdictional boundaries and disciplinary boundaries, which tend to be very rigid and fixed. And so it takes a lot of effort to break down those walls between, Ministry of Health, Ministry of Agriculture, between doctors and veterinarians and epidemiologists. So there needs to be a lot of sustained effort from the top to make this happen, and creating the right kind of incentives and structures to make this happen. At the same time, you also need that kind of bottom-up approach where the practitioners and the people on the front lines and in the trenches need to understand why it matters that this is a One Health enterprise, that it's not just a medical issue, it's also a veterinary issue. It's not just an agricultural issue, it's an environmental issue. And having the individuals at the front lines understand their role in this broader One Health approach to public health. And so I think both those types of approaches need to be made at the same time. To basically, working in this as a supply and demand issue, right? There needs to be demand from kind of practitioners, and there needs to be demand from policymakers, but also supply of people who understand these issues, can work at this interface of human health, animal health, environmental health issues, and really push these agendas forward. Because even if you get policy at the top, right, what really matters at the end of the day is the implementation at the ground level. So that's why you need to have multiple layers and multiple strategies pushing it forward, which is, I think, why it's taken so long, especially in the US, but other countries, to adopt One Health is really kind of a bedrock principle of public health. And it'll probably take a bit longer, even though the value of that approach is, I think, has been proven by this pandemic. It will still take a while to break down those remaining barriers to achieve the vision of integrating, human health and animal health in a really meaningful way.
If I could tie a comment that Jerry made to a comment that Greg made about all being about communication, I think that's key for One Health approaches, right? There are a number of countries that have, if you look at, for example, systems in place, let's say at the Ministries of Health, there's typically a zoonotic disease unit, but they're always focused on zoonotic diseases that are, of course, impacting humans and human health. If you looked at asking each ministry or stakeholder to map out what their priority diseases are from a One Health approach, I guarantee you there may only be one or two that are going to be the same on the list from an environmental, ag, wildlife, and human health perspective, because the diseases that drive financing, response, surge operations in a veterinary sector are not going to be the key zoonotic diseases that may spill over and create a human epidemic or pandemic. And so I think it's important to have that communication, the coordination at both subnational and national levels to think about how we discuss One Health. The discussions in the States are going to look very different than the discussions in Kenya, and that's okay. But having the right conversations with the right stakeholders to understand what the needs are at the national level, at the regional level, and then try to implement a global strategy, I think is important. So communication all the way.
Then I would add education. And education specifically for the next generation. I'm much more confident that our next generation is going to drive the multidisciplinary One Health approach that's essential. I'm not sure if my generation is going to get it in time, but I have complete confidence in the next generation. But that's why all of us involved in this discussion today is we need to make that one of our priorities, and communicating and educating and mentoring the next generation of why this is important.
Thank you so much for those responses. A couple more questions, and then I think we have to wrap up with a few final closing thoughts. I do want to make sure there's some great questions here. Are there geographic zones that can be considered as potential for the next pandemic? Can we drive One Health through WHO? I think these are enormous. So I'm going to bundle these with some of the earlier questions that are more specific to biosafety and biosecurity, and just invite you each to give some closing thoughts to these questions. The observations that really come down to a shared set of questions, which is, what do we do to extend biorisk management beyond the borders of the specific designated microbiology labs, so that we include the clinical areas with biorisks, the limited capacities in the field. So we think about supporting biosafety for frontline healthcare workers moving forward, and thinking about COVID-19 bio-wastes, which even many labs that were prepared to handle the virus were not prepared for the wastes. So I'd love to think to collect your thoughts moving forward on, again, each of our panelists. Jerry, I am going to begin with you, and then to Greg, and then to Erin, to think about responses to some of these really, really thoughtful questions in the minute or two that we have left.
Well, we absolutely have to extend our biorisk management beyond just the high containment labs and then all microbiology labs. It is something that in the clinical setting, in the field setting, we have to address all those. And I was just reminded of just in Texas, in a hospital in Dallas, when we had to care for an Ebola patient back in 2014. And unfortunately, he lost his life to Ebola, but two of his healthcare workers who were courageously trying to save his life also contracted Ebola. But just dealing with all the hazardous waste from that one patient and two extra patients was enormous. And we hadn't thought about those in our hospital preparedness type efforts. And I'm not sure we did too much in the interim between 2014 and 2020 to prepare us for that onslaught of just biorisk management in all settings beyond the laboratory. And so again, this is a lesson observed that we're going to need to turn into a lesson learned post-COVID in our preparedness to deal with biorisk management in all settings. Over.
Thanks so much. Greg, your thoughts?
Sure. So to borrow a phrase that's popular in DC now, we need to build back better for biorisk management. The pandemic has revealed a lot of gaps and vulnerabilities and weaknesses in both biosafety and biosecurity, dual use research oversight. The silver lining here is that the costs of getting this wrong have also been, very vividly demonstrated by the pandemic and the human toll and the economic costs and just the disruption to societies. So I think that makes it, easier for people who want to put in place, better safeguards against those kinds of risks or push a One Health approach that even though it will, be difficult, it will cost money, it will, require us to do things differently, right? The costs of failing to adapt and innovate, I think, have been pretty vividly demonstrated. So that should help facilitate making kind of the serious kinds of structural reforms we need to make at both, within nations and then the international level as well. And I don't, underestimate how difficult it will be. But I know that there is a lot of folks both on this call and elsewhere who are very highly mobilized to make a difference here because they've experienced the pandemic firsthand and have a lot of great ideas about how to either prevent future pandemics or at least mitigate the consequences of the next one. So I think it's really key to mobilize that energy and effort and try and make some structural changes to enhance our ability to deal with the full range of threats that we've been talking about today.
Thank you. And Erin.
I think just to try to wrap that up, I think biosafety, biorisk has always been lab focused and lab centered and looking into the lab, right? And I think as Greg mentioned earlier, the minute you walk out of the lab, that concept of biosafety in the field is minimal if existing. And so the onus is on the individuals that are working in the field, collecting the samples, responding to the outbreak, whether that is at an animal, human, environmental interface. All of that requires biosafety in practice and in application. We can just look at the last two spillover events from coronavirus and looking at the nosocomial transmission of SARS and MERS and the amount of cases that occurred because of that. I think it was over 20% of MERS cases to date have been in healthcare workers. And so thinking about how we protect our communities that are protecting us and the training that is in place and using the last few spillover events, whether it's from a coronavirus, an influenza virus, name your zoonotic disease at risk, and think about the implications of waste management, not only in the lab perspective, but in the clinical perspective. Think about PPE, not just in the lab, but in the field and in the primary and secondary healthcare facilities. All of these things are critical when we think about biosafety and thinking about the application beyond the lab.
Thank you so much for that. We are at the very end of time of our time, not the end of time, our time here together today. We have had a suggestion to develop this as an in-person workshop. We have collected all of the questions here. If you have other questions you would like to have answered, please contact the organizers of this who are on your invite, and we'll make sure that we can respond to questions that weren't answered. I would like to ask each of our participants to give 30 seconds just a lightning round to end. The one takeaway, the one thing you would like to see acted on that we have learned from this pandemic, if you had 30 seconds in an elevator with all the world's leaders, what would your one recommendation be?
I'll start. We've got to fix the communication problem. We have to regain trust and confidence in our public health authorities, government authorities, and it's going to take communication, risk communication, and we've got to do a better job of translating complex scientific topics to the public and regaining their trust.
And I'm going to pretend I'm in the same elevator as Jerry and build on that and say that in addition to having that open line of communication, that scientists are allowed to be wrong, that we learn through an outbreak, just like the public. And so while we may say within the first 2 weeks of identifying a pathogen that this is what we believe to be the risks, in a month, based on evidence base that we've developed in the lab and through scientific collaboration, we should be allowed to acknowledge a mistake and say, now we see that based on what we've seen both in nature and in the lab, here's what we need you all to do to practice good public health. And so I think we have to acknowledge that science, just like everything else, learns from its mistakes and should be able to inform future directions.
All of the above, plus, national leaders need to really understand that pathogens don't carry passports, pandemics don't care about borders, and there needs to be a much stronger international response to these pandemics, because no matter where it arises, it's going to spread around the world. And areas that are left vulnerable because of lack of vaccine or medical support are the places that could create the next variant that will then endanger every country all over again. So there needs to be a much broader collective sense of humanity's struggle against the virus and not let geopolitics and parochial politics get in the way of that.
So thank you so much to all of you for giving those incredibly thoughtful remarks in such a short time. We could actually, I think, sit here all day and answer the thoughtful questions that are still coming in about dual use research, about legislation, about financing, but we are out of time for today. I think some of these would make great topics for a follow-on event, and we can figure out what we might be able to do about that. I certainly think there will be lots of discussions happening globally that answer some of these questions in the next few months to years. At least I hope that we are having thoughtful conversations about these topics in the next few months to years, because if we do not have the momentum to address these gaps now, I don't know when we do. So I would like to take this opportunity to thank our panelists for sharing their expertise and for their very thoughtful remarks. I would like to thank our participants for the fantastic questions and for everything you're doing, because I'm just looking at the names of the people who are here, and I know you've taken time out of your days, your nights, or your early mornings to be here and be part of this discussion. And some of you, it's very late at night indeed. So like to thank you all for taking the time to join and for being part of our conversation today. On behalf of CRDF Global, thank you all for attending, and I hope to see you again soon in live and in in-person events as soon as we can. Thank you.
Thank you.